Thank you.
Sorry. So, good afternoon. Welcome to today's 60-day report out. My name is Kirsten Leach and I'm the Senior Sister on Ward 24 at the LGI, which is Female Neurosurgery, and I'm a process owner. So as you said, our project is to look at reducing the time a patient waits from hearing that they are ready for discharge to actually receiving their medication. And this is to free up beds earlier to improve the flow of patients from our level 3 and 2 beds down to the ward.
So my name's Karen Bowes. I'm the Senior Sister on L25 at St James at the LGI. I'm also a process owner. This is our target report for our progress up to 60 days. It's not at all. You're catching it. Initially, our lead time, which was the time taken from the end of the ward round, which was the decision to discharge a patient, to them actually their eDAN being released from pharmacy, was coming out at 401 minutes per patient. At the end of our rapid improvement week, we were down to it was down to 125, but that was over for one patient. At our 30-day shout out, we split it down into patients that had been pre-populated, so eDANs, which was another part of our process, where the eDAN's been started beforehand, where in critical care they're starting to fill the information in, where the CNSs, the specialist nurses for the head injuries and the vascular team are starting to pre-populate. They've started filling in the eDANs beforehand, and the ones that weren't pre-populated. We had a minute time of 316 minutes for the ones that weren't pre-populated per patient, but we were down to 88 minutes per patient for the ones that were pre-populated. This time, we've had none of the eDANs that we looked at last week had not been pre-populated, so they'd all been pre-populated, and we were at a lead time of 128 minutes, which makes us 96% of our target, which is cut down from 401 minutes to 128, although I acknowledge that's over 9 patients over a 2-day period within the unit. One of the other areas we were looking at was the quality defects, so that initially when we first started it, none of the eDANs were pre-populated, none of them had any information in, so the doctors were coming at them cold. Now they're coming at them and they've got information in, and they've got pertinent information in. So the head injury nurse is putting in whether they're being followed up at the head injury clinic and who's following them up, whether it's a doctor follow-up, whether it's a nurse follow-up, and every single one of them last week had been started by somebody, whether it be Ward 28, they were coming in as a day admission and what they're coming for, whether it was the head injury nurse, whether it was a vascular nurse, or whether it was a step-down patient that they'd been started. The quality defects, that one. The medical staff interruptions. We find that when medical staff complete the eDANs at the nurses' station, as anybody does, they get interrupted, and they were getting interrupted 100% of the time. We tried to identify an area where they could go away from the nurses' station and complete the eDANs without any interruption. At the 30-day shout out, 9 of the ones were still interrupted and did them at the nurses' station, but the 8 that went off to this specific area to actually do the eDANs, only one of them were interrupted, and they were getting a quicker time to do them. This time we've been unable to measure that, and just because of the bed pressures within the area, my eDAN preparation room has got my corridor patient in, and so it's not available. But they were so the doctors that we were looking at that point, they're still being interrupted because they're not able to come away from the nurses' station. And the set of production time, which was the time from the doctor actually starting the eDAN to being released from pharmacy, initially was set at 28 minutes. Our target time was to get down to 9 minutes. This time, again, we couldn't. We've measured. The last 9 of the last week that we measured, we got a target reduction time of setup time. Of 10 minutes.
From 1 minute off.
We're nearly there. This is just an example. Our newspaper. It's several. Oh,
Is it me? Sorry.
Yeah.
Can't do anything else.
It's several pages long, so I've just given you a snapshot of it, but I'm giving you a snapshot that we're really proud of our pre-population. The CNSs have run with it. They go in and they ask us, but they will start as soon as they meet with the patients, they'll start putting information in. There's been some comments from some of the medical staff that maybe there's too much information, but I don't think we can ever give the GPs too much information. And at least this way they're putting whether they're being followed up by them in a specialist outpatient appointment or whether they're being followed up in the doctor's appointment, and then these patients are now not getting two follow-up appointments.
Hello, my name's Liz Drew. I'm the pharmacist for neurosurgery and team member. We looked at the process of bypassing pharmacy when discharging patients with eDANs, electronic discharge advice notes. So we did have this system available in neurosurgery, but it wasn't well known about and it wasn't widely used. So the aim of bypassing pharmacy is for those patients with the most straightforward eDANs, maybe just simple analgesia and laxatives, to save the discharge prescription from needing to go to pharmacy for those to be dispensed. It can just be dispensed from a cupboard on the ward by nursing staff who are suitably trained. So this runs across both wards L24 and 25, and as you can see, since starting this work stream, we have increased the proportion of patients whose eDAN is able to bypass pharmacy from 15% to 29%. This enables the discharge process to be streamlined for the doctors because then they don't have to put all the regular meds on the discharge advice note, only the ones that need supplying, so paracetamol for example. Easier for nursing staff. Pharmacy is bypassed during this process where appropriate, where it's the simplest patients, and obviously benefits for the patients as well. We have obviously trained the doctors involved in this as we've gone along within the project, but with a new set of doctors starting with us in August, training on this will be included as part of their induction to our area, so we can catch them right from the beginning. And by not supplying regular medicines for patients, we've got both time and cost-saving benefits. I have had feedback from pharmacy colleagues who cover the discharge processes on an afternoon that they're seeing many fewer discharges from neurosurgery in an afternoon, which is beneficial from a turnaround time point of view as well as workload, and enabling the most appropriate, relevant pharmacist who knows the patient to process their discharge in the morning perhaps. We also, to enable the bypass pharmacy function to operate, have a pre-packed medication cupboard on the ward that the nurses can access. And our pharmacy technician, Sarah O'Neill, has done a lot of work in making this cupboard more effective and easier to use for nursing staff. We've improved our standards even slightly higher since 30 days by sharing our learning, collaborative working with our colleagues in the urology work stream who've also looked at this aspect of discharging. And as we continue along the work stream, we continue to review the contents of the cupboard to make sure, actually, is there anything else we could put in there that would be useful to have nurses using? Have we got the right amount of stock in there? Because the more we use it, the more stock we're getting through. So just simple measures like that we continue to assess in order to meet the demands of the new process and optimally use the function that's available.
Yeah, just on that note, we originally took out all the antibiotics out of the cupboard because we'd looked across 25 and 24 and it not being used from previously when we'd been using the pre-packed cupboard. But we found out that patients are needing that, so we actually put that back in over the last week. I think it was,
So we can continue to amend things.
These are just a few pictures. So our pre-packed cupboard has now been moved into our robot. We've got an instruction of how to. The picture of the nurse's station is a part of this that we haven't discussed today. Was absolutely no drug charts are to leave the end of a patient's bed. So our previous picture at 30 days that was covered with drug charts, now they do not move, they stay at the end of the bed so you can find them when you need them. We started a little whiteboard which was for ease of use for everybody to see where the eDAN was and which process, which stage it's at. And we did a little checklist for the nurse in charge to ask the correct questions at the right time so that we're not chasing that information throughout the day, so that the eDAN is done first thing on the morning. So they're just a few pictures.
So our successes and challenges, just a few of them at the moment. More use of the eDAN prep room. medical staff are actually seeking it out now, and they're a little bit perturbed at the moment that it's not available for them, but they're actually, because they know that when they're getting there that they can do the eDAN and they're not interrupted and it's less time.
So our medical engagement was fantastic up to 30 days, but then he left the trust. We've got somebody else in mind who's offered to help out, starts in August. So we've just got a bit of a gap in between, but everybody's much more on board than they were to start with, so I think we'll be all right for those 30 days.
eDANs are being completed quicker. They're being started earlier. There are some issues when the ward's extremely busy and when you have unexpected patients deteriorating on the ward. But I had a doctor who came to this morning and went, at 9:20, I've done 2 eDANs, and he was really proud of himself that he'd done 2 eDANs.
And as you've seen, we have increased the percentage of patients whose eDANs are bypassing pharmacy for a more streamlined discharge where appropriate from 15 to 29%, which we're really pleased with.
So thank you for listening, and we'll see you again at our 90-day report out sometime in August.
Stay with us. Thank you all for that, and some great stats after 60 days. What we're trying to do is demonstrate that this just becomes part of normal practice, and that's why we do them at 30, 60, and then at 90 days, and keep on going really until that they become embedded. But is there anyone got any questions for the team?
Just asked about your step downs. Has that doing eDANs earlier? Has that enabled patients to step up quicker, better?
Yeah, so before we started this process, I think it'd be fair to say that most of our step downs happened after 5 o'clock, midnight, that kind of time. And bearing in mind the level of, some of our patients have tracheostomies and things like that, it's not a safe time to be doing it. So our eDANs now have been getting done at 9, 10 o'clock in the morning, not 4, 5 o'clock. So those patients are leaving, the bed's turned around much quicker, that step down is definitely improving.
It's not where we want it to be yet.
No,
but it is improving. I had a patient on Tuesday who said, I can go home, I'm just waiting for me letter for the doctor. I've been told it's going to be in the middle of the afternoon, everybody's told me at home, and I'm like, no, actually, you'll be ready by 11. And he was.
Helen?
I think you've done great. Well done. Congratulations. It's really hard, isn't it? So I was just thinking about some of the structural things that we have in place at St James's that I don't think are in place at Jimmy's at LGI. I'm just wondering about those. So we have a discharge lounge here, and lots of places have e-meds rolled out. So I just didn't know whether the timescales for e-meds in your CSU and a discharge lounge, obviously that's a bigger decision than you guys at the LGI, but
I think the discharge lounge was discussed and decided that we weren't going to do it because it's just putting a patient somewhere else to wait. Rather than making the patient wait, we wanted to tackle it and get them out straight away. So I think that's right, Sarah, that we weren't at that point.
From a process perspective, we didn't feel that having that extra step would be helpful. I know when the CSU got together for the LDI science meeting, we have discussed the potential of a discharge lounge. So it's not completely ruled out, it's just where it could be.
And I just think for a lot of the patients from neurosurgery that are spinal operations, if they've had lumbar surgery, they can't go sit in a chair waiting. They've got to have the option to lay down. So it's standing and walking or laying down. They can sit for a short period, but sitting for a prolonged period is something they can't do. So there's some of those that have got some issues.
And I think we're due for rollout for beginning of next year.
Towards the end of this year.
It's moving slightly, but I think end
you'll
of the
just
year.
take all that good practice and drop it into an electronic.
Well, it should make it even
Something
quicker
easier.
because
Yeah.
So we're hoping that it'll get better by the end
So
of
what
the
are you
year.
using at the moment? Is it Blue Spear?
Yes.
Yeah.
Blue Spear, yeah.
Yeah.
Thanks, Nigel. Question?
I just wanted to ask, how do you prioritise your eDANs to your medics? So do you do that the night before? Because they're done so early, 20
No, we have
it before board round.
It's very neurosurgery is, I don't know what it's like in other areas. On the morning on neurosurgery, between 8 o'clock and about 8:45, I have 3 ward rounds that do every single patient on the ward. And by the end of that, I will, between that and 9:30ish, I will know the patients from that day that have been discharged. And then as I'm going round with the doctors in the checklist, I'll just say, Fudge, I need an eDAN, Fudge, I need another eDAN, and that's there. But he marks that down as well. but then we put it on.
Sorry, we are trying to start it so that we can preempt, our simple lumbar spines. A couple of days, we need to preempt that. We need to get it done the day before. We're not quite there, but we are in the process of.
Having said that, out of those figures, 2 of them were a 0 day because they were already prepared the day before.
But that depends on how many medics you've got and how busy the ward is, and that's not something that's always easy to figure out.
Can I just check with you, just I guess sort of informal feedback? So 24 is the female ward, and 25 is the male ward. And we talked about 24 and 25. Do you think it's equally embedded, or is any area doing differently to others? Is there anything at play there?
No, I think it's equally embedded. I think maybe the checklist is slightly more embedded in 25 than it is in 24, but I think the board is slightly more. So I think across the way, but we're next door to each other, and the staff are very interchangeable and they work very well together. So.
I just wanted to check with Liz as well. I don't know, do you have to be called Liz to work in pharmacy, Liz? Is that yeah. You can't go to a meeting about pharmacy without someone called Liz being with you. But that was really impressive stuff, wasn't it? From 50 to 29% in terms of that bypassing. I mean, is your sense that outside of this area there is a significant gain for us to be made there as well with the bypassing of pharmacy?
Well, the bypassing pharmacy function operates in a number of other areas already. For example, ENT and urology and some areas of surgery already use it. It tends to only work well for those patients whose discharge prescriptions are quite simple. So I think in a lot of medical areas it might be quite difficult. But certainly we've collaborated with the urology work stream to share our learning, and because of people who work in that group work wider across surgery here at St James's, that's something we'll certainly look at to see if we think it could be of benefit. We need to be mindful of the fact that if we are not putting a patient's regular medicines on their discharge prescription, there could be some consequences of that in terms of clarity of information for the GP. So we can't just run with it and apply it to everybody, but certainly for some patients it's very useful.
Great. Any other questions?
Can I just ask if the consultants are contributing to pre-populating the eDAN at all?
So you would have to ask that.
The urologists are.
So we discussed it, and they use a different system to write their op notes, and that system doesn't link yet to the blue spear that we're using.
Yeah.
So they are happy to do it, they're just not going to do it twice.
No, and I think when you go to eMeds and the system's linked to PPM, that will be...
Yeah. But the information is there, it could link easy, but that's an IT issue, and that's like what we call a parking lot, something that's too big for our 90 days. But we did come up with, so they are on board.
Thanks very much. We've got, so that was the 6-day report out, as you said, we'll be back from the 90-day report out. We have a meeting as a sponsor team, actually after this meeting today, and we'll be looking at our next Rapid Process Improvement Week for this value stream. And I think that's likely to be in October, and is likely to be looking at patients with a tracheotomy and about how we transfer those patients as the next part of looking at that pathway. So we'll be following through with those inch-wide, mile deeps all along the part of that process. But should we just thank you again for doing that?
Can we just thank both teams,
Yes.
Dean, because I know it's really hard to keep things going. One of the things that we're learning with all of the value streams is that the amount of commitment, energy and enthusiasm that is in the RPIW week is really hard to keep going once you get back into your workplace, and that's just because of the pressure of work. And so I think the achievements being made by both the teams that are presented today are really significant, and thank you very much indeed.
Thank you very much for attending. Watch out for the next ones of these coming up. If you've enjoyed it, come back again and let your friends and colleagues know. If you've got ideas of stuff that you want to report back on here, then let someone like Chris or Jimmy or Sophie know, and we can include the report out in these events as well. But thank you very much.
Thank you.